Good morning, one and all. We are starting with the webinar. I, Mr. Amol Temkar, Associate Professor on behalf of Dr. Vithalrao Vikhe Patil, College of Nursing, welcome you all for today's webinar on application of nursing theories in clinical practice and research. Just brief about College of Nursing. Dr. Vithalrao Vikhe Patil Foundation is located in the state of Maharashtra, district Ahmednagar. To begin with, I would like to introduce our pioneers. Dr. Vithalrao Vikhe Patil, the pioneer of sugar cooperative movement, who had a humble beginning, was chiefly instrumental in organizing the much exploited sugarcane growers of the village in around Pravaranagar. He establishing Asia's first cooperative sugar factory, which was commissioned in 1950. His untiring efforts changed the rural sense of Maharashtra and created awareness among the people to lead a prospective, purposeful life. Honorable late Dr. Balasaheb Vikhe Patil, founder chairman, to realize the visionary thoughts of Padma Shri, his worthy son, Honorable Padma Bhushan Shri Balasaheb Vikhe Patil, established Dr. Vithalrao Vikhe Patil Foundation in the year 1982 with sole aim to spread technical, medical, paramedical, Ayurvedic education in developing rural areas, thus contributing immensely towards national human resource development. Honorable Namdar Shri Radhakrishna Eknath Vikhe Patil, he is a guiding light and a soul in development of Dr. Vithalrao Vikhe Patil Foundation in contribution to visionary thoughts of Honorable Shri Balasaheb Vikhe Patil, the predicted future plans and begin implemented under his dynamic leadership with prime aim to provide quality medical services to rural as well as urban masses. Honorable Dr. Sujay Radhakrishna Vikhe Patil, Member of Parliament, Ahmednagar Parliamentary Constituency, Chief Executive Officer of Dr. Vithalrao Vikhe Patil Foundation and neurosurgeon. In April 2012, he took over as Chief Executive Officer of Dr. Vithalrao Vikhe Patil Foundation. Since then, ultra modern and well equipped administrative as well as academic buildings have came up. We are blessed to work under the able leadership of Lieutenant General Dr. B. Sadananda, Secretary General, Dr. Vithalrao Vikhe Patil Foundation, and Dr. Abhijit Divte, Deputy Director, Dr. Vithalrao Vikhe Patil Institute of Medical Sciences. Now, I kindly request our respected principal, Dr. Pratibha Chandekar, to take over the session. Thank you. परत accept करतो मी काय. Yes. Waiting room. श्रीदेवी मॅडम आल्या ॲडमिट. सॉरी मी एक काम करतो, मला म्यूट करतो अगोदर.
Okay. Good morning to all of you. I welcome on behalf of Vithalrao Vikhe Patil Foundation College of Nursing, Ahmednagar, for this webinar on application of nursing theories in clinical practice and research. Application of nursing theories in clinical practice and research. The nursing theories, or theory is the word we look into Latin. It is viewing. In Greek, it is contemplative. So, a view, so nursing theory, it is a view or a conception, and it is a mental scheme, a system of ideas intended to explain a group of related concepts, definitions, and statements that propose a view of nursing phenomena from which to describe, to explain, or predict outcomes, values, and beliefs. So nursing must be viewed as a scholarly academic discipline that contributes to society. So theory guides the professional nurse in organizing and analyzing the patient's data and making sound clinical judgments based on evidence, planning, effective nursing interventions, and predicting and evaluating the outcomes of interventions. The major concepts of the discipline in our nursing practice, the most important to practice and research, are the four concepts. That is the person, the environment, the health, and nursing, which we call as meta paradigm. So linking of the science and philosophy is the core. So nurses intentionally structure their practice by using the nursing theory as a guide in their care of the patient. So what is the purpose of nursing theory?
Sorry for the interruption. I request all the participants to please put your mobile on mute mode.
Priyanka Chandade.
I'll put.
Okay. So the purpose of nursing theory, it enables nurses to know why they are doing what they are doing. Okay. So knowing what we are doing and why we are doing, that is the main underline behind this. So we have to be based on a sound theory in our practice. So if we are aware, so we will be able to scientifically speak to the scientific community. So to embark on this, we have stalwarts, dynamic speakers whom I'm going to present before you. All are leading professionals, and I have privilege, or I would say I'm proudly privileged to present before you my three colleagues in this profession. All are LT College of Nursing, SNDT Women's University alumni. So I bring before you Dr. Sri Priya Gopal Krishnan. Next slide, please. Who is presently working as professor and principal at Sadhu Vaswani College of Nursing, Pune. She is graduated from SNDT Women's University, postgraduate from CMC Vellore, and has done her PhD in nursing faculty from Bharatiya Vidyapeetham University, College of Nursing, Pune. She has over 28 years of experience in various reputed institutions. She's passionate about nursing research. She has published over 20 papers. She has guided several PG and doctoral students and specialties including oncology nursing and nursing research. And as a teacher, we all have responsibility in conducting the examination. And she is awarded as a best teacher in 2002 by Rotary Club of Pune. And presently, she is striving to set the quality benchmarks in nursing education. So hence, also she is actively involved in SOMI activities, that is Society of Midwives, and also she is the Board of Study members, Research Recognition Committee member of various universities. So on behalf of Dr. Vithalram Vikhe Patil College of Nursing, I welcome you, madam, for this. Next, I present before you my friend, Dr. Shobha Gaikwad, who is the assistant professor at LT College of Nursing, SNDT Women's University. and she has done a PhD in nursing, and she is with the CVTS specialization, and she has done MA in sociology and also has done postgraduate diploma in education management. And she is the recipient of fellowship in International Society for Quality in Healthcare, Ireland. And she is having 29 years of experience. Also, she has around 30 papers, publications in peer-reviewed and impact factor UGC recognized journals at national and international. And she has received till date 5 first prize for science presentation at national and international conferences. She received first prize for concept mapping, and she has received second prize at SNDT Inter-University Avishkar Research Convention for Best PG Category Research Guidance. So we welcome you, madam, for this deliberation. I present before you the third speaker, a dynamic whom I know from 1980, Mrs. Sri Devi Balchandran, who is presently working as lecturer, Sultan Qaboos University, who has done her BSc and MSc from LT College of Nursing, SNDT University. Next, please. Okay. She is passionate about nursing and being a nurse. Okay. So I know in every forum, even in social media or any other platform, Sri Devi always, she's so much passionate about nursing profession and this nursing as a profession. She wants to represent it, and she doesn't tolerate our profession being undermined by anybody. I know her, and she's very well known and respected by even other faculties. I remember once in Pravra when I was Principal College of Nursing, Dr. Ravi Bapat, a well-known surgeon, he remembered and he quoted her in the expert gathering. He says, Sri Devi, a brilliant and teacher. So this is, she was a student 30 years before, but was recalled by a well-known surgeon. So now currently she is working in Oman since the inception of the first Bachelor's of Nursing program at the Sultanate Qaboos University for last 16 years. Okay, she's a registered nurse in UK, Australia, and Sultanate of Oman. She worked at PD Hinduja Hospital for 5 years, and also she worked in Royal Brompton Hospital, and she has worked in Manipal Hospital, Bangalore, as the first director of nursing in 2000. And she played a vital role there. She brought many sweeping changes. She established any program there. She inculcated professionalism among the nurses, and she eliminated the non-nursing functions, and also she brought in a professional looking uniform and infection control department she installed, and also patient safety requirements she brought in there. Okay. Then she worked, she's working as faculty in Sultan Qaboos University. Next, please. And currently, she is the principal investigator in conducting the research which is being undertaken by her guideline for perioperative care in cardiac surgery, a survey of nursing staff in Oman. Then she is co-principal investigator for students' perception of e-learning at Sultan Qaboos University, Oman during the COVID-19 pandemic. And also another 2 more research projects which she is been undertaking now currently. She has reviewed 10 reviews of the journals in British Journal of Nursing and Sultan Qaboos University Medical Journal. She has received Dr. P.N. Berry Scholarship, and also she has received the best teacher in 2012 as from Sultan Qaboos University. So we welcome you all 3 experts to embark on the application of nursing theories in clinical practice and research. I call upon Dr. Shri Priya Gopal Krishnan to speak on this. Can I host her?
Thank you, madam.
Yeah. Only we have little, shortcoming. That is, every speaker will have to become host. And once you finish your session, make the host to. Now, next is Dr. Shobha Gaikwad. Thank you.
Can I share my screen?
You are able to do, ma'am?
No, I'm just trying, ma'am. Just 2 minutes.
Oh, yeah, no problem.
Is the PPT visible? Hello?
No, ma'am.
Ma'am, is it visible now?
No, not yet.
Ma'am, I'll try to log in through my other instrument.
Okay.
Is it okay?
Madam, would you like to send it to us?
I will just log in through my PC. This I'm trying to log in. I'm on my tab, but I'm not able to share. So I'm logging in through my PC. It's already open.
Yeah.
Just give me a minute.
Actually, through tab, it is not possible.
Yes, I think so. That is a problem.
Yes. me
Hello. Hello.
Yes, ma'am. Yes, ma'am.
Ma'am, it's taking some time. I think you let us proceed with the next speaker. In the meanwhile, I will join through my PC.
Sure, sure.
Is it okay? Because I
Yeah,
don't
it
want
is
to
okay.
waste everybody's
Yeah,
time.
yeah.
Huh?
Yeah,
So
yeah,
just give me
okay.
a few moments. I will join. And I think
Okay,
you will
okay.
have to tell them
Can
to
I?
let me in through
Can
my
I
PC.
request Dr. Shobha Gaikwad?
Hello, yeah, Dr. Pratibha. I can take the session.
Hello?
Yes, Dr. Pratibha.
Yes, yes.
Am I audible?
Madam, yeah, voice is little slow.
Can you hear now?
Yeah, we can hear you.
Okay. So do you want me to start the session? I can do it.
Okay, I'll just request Shri Priya Madam to make you host.
I think
Ma'am,
I
I have
able
joined
to
through the
share.
other system.
Dr. Pratibha, I think I am able to share. Should I share it?
You can
Yeah,
share?
please share.
Yeah,
Please
yeah,
share.
I can share.
Yeah, yeah. Go ahead then.
Please go ahead.
Okay, before I start, good morning to everyone, especially Dr. Pratibha Chandekar, ma'am, for inviting me for the session. I know we are taking theory related to practice and research. I'm using a different platform. It's not the occasional PPT. So I hope it is visible to everyone. And if there's any issue, do let me know on the way. Okay. So first and foremost, let me just share my screen.
Dr. Shobha, if you can take your mic closer.
1 minute. Is this audible loud enough? Am I audible now?
Yes, yes.
Okay. So just to go ahead, let me just share my screen first. Okay. Do let me know, is the screen visible?
Yes, it is visible.
Okay. So once again, good morning, everyone. I'm using a concept board application. So you'll find a little extra matter on it because that is how a concept board is usually made upon. It's a new form of Prezi. Okay, so today I'll be dealing with two different non-nursing theories. Okay, nursing theories all of us have seen. Okay, so non-nursing theories are also very important when we talk about uh, application in nursing and research. Okay, so the two theories which I will be dealing upon today are Erik Erikson and Hildegard Peplow, which I will be doing it a comparative form with an example, and then how are both of them correlated and why is it important in our nursing practice. So when we talk about Erik Erikson, I'm sure all of you know it is a psychosocial theory. It talks about a person's life from the birth to the death and the various interaction when we come to it. So whatever is there, the nurse has to have a good understanding of Erickson's developmental theory. Why do we require that? We require it so that accurately you can assess and provide age-appropriate nursing care as you're taking care of the patient. Here, the nurse is able to respond better to the patient if she knows the developmental stages of the patient very well. That means a good, thorough nursing assessment is what is important when you take care of the patient. When we talk about Hildegard-Peplow, it is more interpersonal relation theory. The emphasis here is more on anxiety and how do I deal with the various anxiety levels which are there, which we'll be seeing in the further slide. When we talk about Hildegard-Peplow theory, it is how well you allow the patient to participate in his or her own health care. That is, including the patient in the care is very, very important. And that is how a nurse-patient therapeutic relationship can be built. And as a result, you should be knowing the core level of anxiety and how do I adapt and cope in all the stresses of life. Moving further, let us see just the difference between the two theories. As we all know, Erik Erikson is an expansion of your Freud's concept of ego, that is, the human personality, the shape, which starts right from the age 5 till your late adulthood or whatever it is. Okay. So here it is what is very important that I understand the various developmental stage. Each stage, as we know, is very unique as per Erikson. When we talk about unique, that means each stage has a crisis. Every person has to face the crisis, and that is a challenge which helps us that you resolve the crisis and then you move to the next stage. A person faces various challenges, but how do I master this? That is what is important when I talk about Erikson's stage. Now we come to the next one, that is Peplow. Peplow again believed, as I told you, interpersonal relationship. Interpersonal relationship, when I talk about, it is more on based on the 4 levels of anxiety. This levels of anxiety, what is the level I am into, and then how the nurse identifies the level of anxiety and what role she plays in this particular thing to help the patient decrease. Because if I have anxiety, I will have insecurity, I will have stress, I will have anxiety. So can I relieve this? And this can be done only through a therapeutic nurse-patient relationship. Here again, it depends how well the nurse actually identifies the level of anxiety and then helps the patient by coping. How will the patient cope with the anxiety? If it is done successfully, then there is no disequilibrium. But if there is a disequilibrium, that will lead to many disorders physically and physically. So when I move ahead, as we all know, there are 4 metaparadigms in nursing. When I talk about Erikson, Erikson is, do I identify which are the stages and the stages of development? Where is the issue? Then based on the health, whether I'm able to contribute in the formation of the development by identifying the crisis and helping the person solve it. As we all know, there are certain crises and there are certain virtues. So if the crises are solved, definitely the 6 stages of your virtues or 8 stages of your virtues, that is hope, will, purpose, competency, fidelity, love, care, acquisition, wisdom, that all will be solved. So this the nurse has to identify very well so that the trust is developed between the patient and the nurse and the individual personality can be changed. If it is changed, this will help in the imperative or actual nursing care practice and it is only individualized patient care. It changes from patient to patient. When I talk about Peplow again, as we all know, we are in certain equilibrium and disequilibrium stages. A certain level of anxiety or tension all of us have. Depending on this, what is the forward movement of personality or what type of creative, constructive, productive I can develop in my this so that I can develop my own personality. This helps from internal sources, that is you yourself have the need to develop, and then from your external sources. Now here the external source will be the nurse who's helping you out to build the therapeutic interpersonal relationship, and she helps the client to reduce what? The level of anxiety, insecurity, and stress by various ways. Moving forward, now let us see the key concept between the two things. When we talk about Erikson, we all know, as you can see in the diagram also, there are 8 stages, right? From infancy to death. All the stages are interrelated. One must master each stage before I move to the next stage of development. Now here the nurses, it is actually you are the ones who have to assess the patient's developmental stage, which we'll see in an example further. The nurse, what she has to do is provide more age-appropriate nursing care. When she understands the Erickson theory, she is able to impart this very well. This nursing theory can be used in the practice to allow nurses to respond better to the patient's needs, doing the patient assessment, and it not only helps to master what is lost, it also helps to address the present issue and then move forward to the next stage. When I talk about PEPLAWs, okay, PEPLAW believes that you have to decrease the level of anxiety, stress, insecurity to have a fruitful relationship. Here, the nurse has to have respect, empathy, acceptance when she's interacting with the patient. If this particular thing is not there, the patient is not going to open out to you. So here, the nurse must attend all the client's psychological, physical, emotional, spiritual. We talk about all the holistic needs. All that is very important for a nurse to understand. Based on that, now she has to understand what level of anxiety is your patient in. As we all know, there are 4 levels of anxiety: mild, moderate, severe, and panic. Based on which level is your patient, that is the way you are going to assist your patient. So that will help you whether because higher the level of stress, more the level you can see the patient may have physiological problem in the 3rd level. In the 4th, the patient can be suicidal. So a nurse is very important here to understand this particular level of anxiety. And at the earliest, there is a therapeutic nurse-client relationship. Once you reduce the anxiety, this is what you're going to achieve. Again, it's only to individualize patient care. This will help to initiate the proper intervention and the best nursing outcome that you want. Let us see one example now. A 54-year-old patient is admitted with
Madam Shobha, Madam,
yeah, ma'am.
Little more audible if you
Okay.
could.
So he is paralyzed on his
The voice
dominant.
is little very low.
Very low. Okay, 1 minute. Just hold on. Is it fine now?
Yeah.
Is it fine?
Now it is okay.
Okay. A 54. Let us see one example. I'm sure that what I spoke prior, was it audible to everyone? Yes, Dr. Pratibha.
Actually, it was little low.
Okay. So what do you want me to do? Should I continue?
If you could, yeah, now continue, no problem.
Okay. Through this example, what I've lost back, I will cover up. Okay. Okay.
Yeah.
Now
Please,
let us see this client's situation. A 54-year-old client is admitted to the hospital for stroke. He's paralyzed on his dominant side. Dominant is the one we use regularly. And how is he going to keep his job in construction? He's working in a construction firm. So if he is paralyzed on his dominant side, he cannot move that particular side. Okay. So here, when we talk about Erickson's stage of development, a 54-year-old would be, as we all know, there are certain virtues and certain crisis level. So here the patient is in the developmental stage of generativity versus stagnation. During this stage, what happens in generativity versus stagnation is the patient wants to leave a mark on the generation to come who are going to follow him. He wants to raise his own children, his own family. He wants to be productive at his work or his career place or wherever he is there, even if in his family or in his peer group. Okay. And he believes a lot in involving in community organization, participation, various social activities. When we talk about PEPLO, we had seen there are 4 stages, that is orientation, identification, exploitation, resolution. We'll see in the further slide also what it is. Okay, so PEPLO's orientation phase will apply here because it is the earlier stage. The nurse and the patient has to develop a therapeutic relationship here. They have to understand each other. Then only they can be open, and the patient will be open to the nurse and tell all of his concerns, his issues, his problem, and that is how he can seek assistance. So the PEPLO begins right in the first stage when we talk about. based on this, what can be the diagnosis when we talk about at this particular stage? So it is your impaired home maintenance in Erickson when we talk about related to insufficient finances because I am bedridden or I am not able to move myself. I will be on leave for a long time. This is possibly evidenced by expressing difficulty in managing home maintenance. When we talk about PEPLO, it's the grieving, okay, because the patient is in anxiety. What about my future? Okay, so it's a grieving related to the loss of role function, which is possibly evidenced by your psychological distress. The patient will be in distress, the patient will be in stress, will be in some level of the anxiety, which we had seen the 4 levels of anxiety, that is mild, moderate, severe, and panic in the previous slide. When we talk about intervention, now Erickson's intervention will be based on which developmental stage the patient is. This particular example, we have seen the patient is 54-year-old. He is in the generativity stage. Okay, so that is where we are going to tackle the patient into. Peplo, the nursing role, as we have seen, it will start right from the orientation phase. So it's a complete working phase, that is orientation, identification, exploitation, and resolution. So here it is mostly how well you coordinate with the patient through giving respect, empathy, building the earlier relationship, giving various health teaching at various level, and then develop the confidence of the patient and remove the patient from the anxiety so that the equilibrium is mentioned, which the patient also already knows that I can change myself. Let us see the Peplo stages. As I told you in the previous slide, if you have not heard, the orientation phase now here when the nurse is dealing is when the nurse and the patient, they first meet as they don't know each other, and that is the time the nurse has to develop the empathy, the respect, develop the patient's confidence. So the nurse assesses the health and the need of the patient. The identification is once the patient is comfortable with you, is the patient how he feels capable of dealing with his own problem? Does he feel less vulnerable? Does he open out to you? Have you identified his level of anxiety? So based on that, a plan of care is created on the client's condition and the goal. In the exploitation phase, is the patient communicates with the nurse and the actions are taken to deal with that particular problem. The progress is done to the next phase till the patient reaches the final phase and the goal is achieved. During the resolution, the nurse and client evaluates the situation together and determines whether the goals were met or not. At this phase, it is time to terminate the relationship and move towards the next goal which the patient requires to be tackled upon. Now, when we talk about certain questions as per the same uh, example we have seen, what are certain questions I need to tackle and the goal has to be achieved. When I talk about Erickson, each individual, as I told you, has certain challenges or crises to be solved on, and that is based on certain virtues which you achieve. This is throughout the phase of the development. So if I master the problem, then it cannot be a problem in the later life. But if any one stage is not mastered, that means the further stages are going to also have problem. What phase of development was this particular client in? As you have seen, he has right side paralysis. So are there any assistive devices needed for the client to continue contributing to the society? Or is he going to be healed completely? So what is the type of thing which I require for this particular patient when I talk about? When I talk about PEPLO, it's totally based on health promotion, maintenance, okay, your family dynamic, because the patient is already in 54 years, his personal space, is the community, society, resources available? Will he be able to help the community? Is there a family support system? So what is my unexpressed need which I want it to be solved? Based on this, I try to react and I try to solve my particular problem. When I talk about concepts of Erickson and Peplo's theory, Erickson, as we all know, is based on cope, trust, and how do I adapt to the different but difficult situation. Erickson has 8 virtues. Whether those 8 virtues I mentioned to you prior, if you have missed out, that is hope, will, purpose, competency, fidelity, love, care, wisdom. These are to the various developmental stages. So how do I adapt to this different difficult situation? If one does not progress successfully to any stage, This could lead to poor coping and adaptation skill. Whereas when we see peplos, peplos help you to identify the difficulty the patients are experiencing. That is the behavior of the individual patient. That is what we are trying to tackle here. This is done with trust, as I mentioned earlier also, with guidance, so that a lucid or a clear-cut nurse-patient therapeutic relationship is built throughout the care what we are taking of the patient. Now, when we look at into comparison, we see in Peplo in this particular case also, we help others to identify the difficulty. So adaptation is the key when you see Erickson. So it is your trust which we are developing with your patient. Nurse and patient should share a common goal. So it's the competency and the vision, which is your goal, the competency, how well you master that particular skill, your vision, your long-term vision, what you want to be done prior in your life. And when we talk about your generativity versus stagnation, which is our patient or the example which I showed you, that is a care which I'm missing now because of my paralyzed condition, or whether I'll be productive in my further life, whether it is to community or through my family. That is what we look in together. So when we talk about in Peplo, whether we work together, the nurse and the patient, and the therapeutic relationship is built, and that is how it becomes effective when we talk about it. Let us move further. There are certain other problems also in this particular patient which we can think about and think about various intervention. That is a coping mechanism for patient and nurses to use while during the trying situation. So whether I'm able to cope, so is the nurse also able to cope with the patient? So she has to understand him very well, assess him very well, the anxiety level has to be understood very well, the developmental stages has to be understood very well. That is what is important. Second is your patient and nurse understanding one another values, experiences, and expectation. Because if you do not value, then you are not able to identify, and the patient itself will not open out to you. Maladaptation is also possible if the therapeutic relationship is not built at the start only. So then it will be a total failure, and the patient will not open out to you, and you will not be able to in turn help the patient out. Last, there can
Madam
be conflict. Yes,
Madam
ma'am.
Shobha,
Yeah,
yeah,
ma'am.
if you can, in between your voice is becoming low.
Okay.
If your mic is little more closer, it will be better.
Okay. So can you hear now?
Yeah.
Okay. And last is your conflict of your patient care due to staffing and workload. So is that what is not the one which is affecting your patient care? Okay. Now we come to the synthesis of theory and application. How do I apply this theory into the nursing practice? As I told you, both these are non-nursing theory, but a non-nursing theory is also very valuable when we talk about nursing care. So what is important is in Erickson and Peplow, both the theories, as we know, are psychosocial level. So Erickson's help you in determining what level of individual achievement you have achieved, and Peplo shows you, as I told you prior also, what is your own behavior, whether I am able to understand. So both of it in turn helps you for individual development as per the own care only. This cannot be applied to other patient. Each patient is a different individual. That is what you need to understand. So in Erickson, when we talk about, it is a series of age group throughout a person's life and which is measured by individual achievement at each stage. Example, when I talk about trust versus mistrust, is the basic virtue of hope and drive achieved. At each stage, there is a different virtue which you should monitor. The final stage is integrity versus despair. That is your wisdom. So all of us cannot achieve it, but with our own practice, with our own development, if all the stages are achieved, it's very easy to develop and you can learn it. Peplo is your interpersonal nurse-patient relationship, I told. So the nurse's role in discovering what the patient difficulty is. It can be at the medical level, it can be at the physical level, physiological level, social, I meant that is a holistic approach. So that is what is nursing, and we should be able to understand the patient as a whole. When we talk about nurses, we first meet the patient as stranger, then we try to identify everything of the patient. So there you are the leader. Once you are the leader, then you try to give health education, you try to help the patient. That way you are teacher, your mentor, your surrogate. So this helps to reduce the confusion, the uncertainty in the patient, and it helps the patient to build further in a effective way for the society. So, in short, when I talk about, to summarize the topic, Erickson and Peploes are both essential to nursing practice. Erickson developmental theory helps to explain each stage of development a person is. So that means a very good nursing assessment, diagnosis, and intervention is very important to better assess and respond to the patient's developmental stage. Here we talk about communication, care. So it's not only care that you give, the communication is also very important to develop a therapeutic nurse and patient relationship. This helps, as I told you, it is individualized, it is different for each patient. So you have to each understand each patient as a single patient. When we talk about any ICU, cardiac, or a stroke unit, both the places we can very easily apply Erickson's and Peplo's theory in our daily practice. That is, you identify where your patient's developmental stage is, assist him as a nurse in giving proper nursing intervention, and what phase of the nurse-client relationship are you. So that will also help in Peplo's, because Peplo's is, as I told you, what is the difficulty level the patient is in, whether you are able to achieve the difficulty level, whether you are able to adapt to that life, are you able to identify the anxiety, are you able to change the anxiety or reduce the anxiety, how can you adapt to it, and how difficult it is to cope with whatever little anxiety is left. Everything maybe we cannot reduce at its goal, so can we reduce it and have help the patient to cope with it very adaptively and positively. So these are certain references I have taken which will help you in your particular this if you want to go ahead and learn little more in these different stages. Thank you. Dr. Pratibha,
Yeah.
did I take your more time?
No, absolutely no.
I'm sorry, in starting you could not hear.
A
So
little bit.
Okay, thank you.
So, the presentation was very good by taking example and, two combination of two theories. In fact, I just want to put one question saying that how, can we put combination of many theories? Like now you took two theories and gave. So in day-to-day practice, can we take combination of theories and apply on the in the patient care intervention?
Very good question, Dr. Pratibha. But definitely, that's why I told you that I will take two theories and not one theory, because I wanted to show that two theories can be applied. It's not only because these two theories are psychosocial, so not necessary that it has to be a theory from the same family. You can have different theories like Imogen King with your Peplos, because when we talk about our patient, if you know your patient assessment, you are doing very well, what stage your patient is, what is your patient going through, we can apply number of theories together, because that will help in a better care, holistic care. And now is the world of evidence-based research. So every assessment of yours gives the new research question. That's why I've put in the concept board the evidence or the research-based question, which I can have from a single patient. Okay, so it's though we are dealing with a single problem, there are a number of problems and we can apply different theories. And as I told you, not from a single way, like psychosocial only. You can have psychosocial with your Imogen King, psychosocial with Sister Callista Roy. Okay, so there's nothing that we cannot do it. And I do make my master students apply that, okay, the combination of theories and not a single theory.
Oh, okay. So same way in the research also?
Yeah, in research also, because I have used 2 years back, my student has done a storybook formation on CVTS. Okay, so there I did not use a single theory. I've used a combination of two theories and presented in the research. And it makes research also effective. It's only thing, the understanding of the theory and the simplicity of the theory. If you are able to understand the theory not as theory, but when you teach, whether you can teach how to apply with examples to the students, then I think it's very easy for the students to apply it.
Okay, thank you so much, Dr. Shobha, by taking these two theories and then with the combination with the patient example, putting it. I know understanding nursing theory is a difficult topic, but still you made it more simpler with the example, the explanation. Okay, so thank you so much once again. So we move on to the next speaker. I call upon Madam Shri Priya. Are you able to do it now?
Yes, ma'am. Yes.
Yeah, we'll make you host.
Yes.
Shobha Madam, can you just make Shri Priya ma'am as a host, please?
Yeah, I think I'll be able to share the screen now.
Please.
Yes, Shri Priya, I've made you host now.
Yes.
Yeah, yeah, I can. I'm able to share. Can everybody see the screen? Is the screen visible, ma'am?
Yes, ma'am.
Fine. So, thank you, Dr. Shobha, and thank you, Dr. Pratibha, the organizer of this webinar, for giving me a chance and opportunity to speak with my colleagues and alumni. It feels so nice to be a part of this meeting, especially as the members of alumni are here together. Now, I have decided to discuss about one theory in particular.
Madam,
Yes.
your video is off. Would you like to make it on, please?
Ma'am, I'm not able to exit this. I will have to stop sharing screen share. Yes, I
No,
will
it is
start.
okay.
Yeah, I will do it.
It
Yeah.
is okay.
Yes. Now, can you see?
Yes, yes.
Fine. So, what I would like to say is, in nursing, we learn so many theories. But as you see in this picture, it is essential to intertwine theory with practice. This integration is very, very essential. But often, students find so many theories which are available and they get confused as to which theory to use. There is Oram's theory, there's Rogers' theory, Newman, Royce, Watson, so many of them. But before you choose a theory, I would like to ask you a question. Why did you choose to be a nurse? Many of the students who come and join, often the first question that we ask them when they come for the admission interview is, why do you want to do nursing? And most of them say that we would like to care. We want to care for people. And also, you must have heard these common comments from patients who have been admitted and discharged from the hospitals as to that hospital was the worst hospital. I would never like to go back there. They are not at all cooperative. They are very rude in their language. They are not able to care, etc. These are kinds of words. So what is the central thing that we can identify with these kind of sentences that we hear from our patients? And I think as being a nurse for so many years, I feel that one central thing that is missing is caring. The patient doesn't feel he is an important part of the hospital and we are there to take care of them and to help them or guide them back to health. So since caring is a central part of nursing, I am always very taken up by this theory, which is in Watson's theory of caring and practice. Dr. G. Watson said, caring is the essence of nursing.
which is the essence of nursing. All nursing is based on caring. And now today, let us see the integration of this theory in practice. Just a few thoughts which Jane Watson had was she felt that healthcare system has improved, it has intensified the nurses' workload, but in the present workload, often caring attitudes are forgotten, especially when nurses are faced with stressful and difficult situations. You take the current situation of COVID itself, and you will find that nurses are burnt out, nurses are literally frustrated. Many of them are leaving the profession owing to the stress that they are facing. And what happens in this stress is that we forget the caring. Caring is forgotten. We do our work mechanically. Nurses should learn to deal with these complexities arising in every patient situation so that the caring is preserved, because it is the most valuable attribute that we can offer to humanity. The human life requires reverent caring. Dada J.P. Vaswani says that reverence to all forms of life should be the basic philosophy on which our nursing practice is based. Diseases will get cured, but without caring, health cannot be attained and the illness will remain. I'm sure all of you understand the difference between disease and illness. So the illness remains. Complete curing will not occur unless there is caring, health care given to the patients. So before we go to the theory, let us know a little bit about the theorist. Jane Watson was very passionate about nursing. She had some experiences in her life, like she had an accidental injury in which she lost her left eye, and that was in 1997. And soon after that, she lost her husband, whom she calls her spiritual partner and her best friend. And these experiences actually, made her commitment to nursing and caring even more stronger. Although she was born in a small, close-knit family in West Virginia and graduated in 1961 and progressed through her career till PhD in 1973. But and her thoughts on the philosophy of caring science in nursing had started from 1975 onwards. She actually developed this theory. But this loss which she had in her life made her even more committed and actually made her understand the essence of caring to the level of spirituality and to the extent of spiritual connections. She was a recipient of many honorary degrees. I have read about 15 honorary degrees, of which 12 were international. And she has authored many books. Her first book was published in 1985, which was on the science of caring. And she has been a president of the National League of Nursing, a fellow of American Academy of Nursing, going to the highest position, being a distinguished professor of nursing and a chair. She established the Watson Caring Science Organization, and actually in 2010 to promote the learning of caring science. And this website is also being launched. She's a founding member of this association, and she's a director. Even today, she's very passionate about this. In October 2003, she was inducted as a living legend by the American Academy of Nursing. This is just the tip of the iceberg. I have not gone into the details, but it's a very interesting read to learn about her life. So many awards of these three prestigious awards she has received, and these three, that is the Fetzer Institute Norman Cousins Award, International Fellowship in Australia Award, and Fulbright Research Award in Sweden. Other than this, also she has received many awards, but as I told you, I'm not going into too much detail. Only I would like to emphasize the fact that she was very passionate about nursing and has been working since 1961, and she's still working, and that is really very great. So what's this theory about? The theory of human caring, transpersonal caring. What does this theory say? This theory has 7 basic assumptions, and these 7 basic assumptions are actually outlined here, as you can see. in which Jean Watson says that caring can be effectively demonstrated and practiced. It consists of the curative factors. She had given 10 curative factors, and it results in satisfaction of human needs. Effective caring promotes health and individual family growth. Caring responses should accept the person not only as how he or she is now, but what she or he may become. Caring environment offers development of potential while allowing the patient to choose the best action. Science of caring is complementary to cure, and the practice of caring is central to nursing. Now, as you see, these basic 7 assumptions which she has given are actually a sort of holistic, looks at a holistic care approach to the patient. So it's not only about the patient, but also about his family, about his environment, about everything that relates to promoting health in the patient. So these were the major conceptual elements that Jean Watson has emphasized on. That is the 10 curative factors, the transpersonal caring relationship, the caring occasion, and the caring healing consciousness. As you can see in the picture that is given here, the caring moment, the caring healing consciousness, transpersonal caring relationship, which is very essential and is the base of the Watson's theory of human care. She said that for nurses to function, these 10 character factors or processes, caritas in Latin means to cherish, and these character factors or processes are essential. The first character was embrace or loving kindness. She says that the process of embrace or loving kindness includes or involves sustaining human altruistic values by the practice of loving kindness. See, this is a part of nursing care. Every time we give care to the patient, it is necessary for us to give care lovingly, kindly, compassionate. These are the words which we keep telling the students also and nurses also from the day they enter the profession. The second character factor is inspire, faith, and hope. That is basically what in this character factor, the process to be used is to be present authentically. That means to listen carefully to the patient, to enable the patient's faith, hope, belief system. And for this, it is also necessary that the nurse should know her own inner world, life, and also she should be able to honor the subjective inner, feelings of the patient. The trust. This is the third character factor, which is a transpersonal thing. Though in this, the process to be used is to be sensitive to self, also others, by cultivating spiritual practices, going beyond the ego self to transpersonal presence. So what this says, like for example, I will tell you, to understand the spiritual aspects of the patient, what they feel, and respecting that, and also at the same time respecting your own feelings and your, being sensitive to your own cultural and spiritual practices. The fourth character factor is nurture, that is developing a sustaining, loving, trusting, caring relationship. Here is where you can, incorporate the Pepler's theory or the Erickson's theory, like Dr. Shobha just explained in the previous session. The fifth character factor is forgiving, allowing expression of positive, negative feelings, listening to other person's stories, so helping the patient, their families, and self to forgive as well as accept it. Deepen is creatively problem-solving solutions need to be done through, the caring process. The continuous presence of the nurse is essential for the patient to help the patient to solve their own problems and to achieve good health. And absolutely self-actualization. If you see the Maslow's hierarchy, which is also similar, Watson's hierarchy, which I will tell you in the future slides, is also similar to that. So self-actualization is the highest one. The seventh character factor is balance, which she says, in which she emphasizes on the teaching learning within the context of caring relationships. So coaching is, has been emphasized by Watson. Then the eighth character factor is co-creating, where creating a healing environment at all levels. That is, helping the patient and the families to create an environment where they can heal. That is a part of the nursing care to be given. And the next one is ministering, where actually we meet the basic needs And these meeting of the basic needs are thought of as sacred acts, touching the body, mind, and spirit of the patient. And of course, the last character factor is openness, opening the patient as well as the nurse's own, self to spiritual mysteries, and also for allowing miracles in life. Like, for example, you're taking care of a mother who's just delivered a baby. You're helping her to bond with her child, allowing her to understand the miracle of life and birth. That would be a caring moment for a nurse who's taking care of a mother and a child. So these characters processes help us to understand that Watson's theory can be applied in any situation. It may be any type of patient in any situation, and it's a holistic thing because it gives emphasis not only on physical needs but also psychological needs, social needs, and all other needs which we talk about, emotional needs, etc. The conceptual concept, the second concept that is other than the characters factors, the second thing that she talks about, or which is actually the core of her theory, is a transpersonal caring relationship. It focuses on the caring one also and the cared one also, that is the nurse and the patient. So all actions, behaviors, languages, feelings, thoughts, senses, energy field, etc. need to be used to allow this transpersonal caring relationship to take place. So there has to be an intersubjective human to human relationship. So actually what Watson was trying to emphasize is that the nurse has to go beyond the call of duty and be one with the patient to actually help the patient to care and cure himself. So what is a caring occasion? So every occasion when we meet and care for the patient could be a caring moment. A simple thing like I still remember I was admitted with COVID to the hospital ward, and I was sitting and looking at the door of my room. So the ward sister came, "What happened, ma'am? No, are you waiting for somebody? How are you feeling?" That was for her the only observation, that I was sitting and looking a little anxious probably. So then I told her that I'm waiting for my son because, I feel like eating something, and he said that he will come. And I was worried that he will come to the ward. So she said, "Don't worry. I will tell him, you tell him to wait down. I will send somebody and get whatever he's bringing for you." That was a caring moment for her. And actually, we don't need to identify special moments when we need to go and especially tell the patient, "I'm caring for you." No, not at all. Watson says every moment you can identify a caring moment. It can be integrated in the care that you are giving. You're going to take the temperature of a patient. That could be a time when you could, by your observations, identify the patient's the expressions, identify the patient is anxious, or just talk to them and make them feel that they are comfortable, they are loved, and they are wanted, their family needs them, etc. So this consists of feeling, bodily sensations, spiritual beliefs, everything that is a part of human life and can occur in every nursing intervention and interaction. These are the conceptual definitions that we know that every theory defines a person, the health, belief, environment, and nursing. So what Watson felt about a person was that a person is a valued person and to be cared for, respected, nurtured, understood, and assisted in the complete philosophical view. And the human is greater than and different from the sum of his parts. It's something a very, very higher spiritual level of connection, which he said that we must develop with our patients. Health, according to Watson, also the three elements of WHO definition are definitely included in the definition. So you can, that is what she also agreed on. Environment, according to Watson, was existing in every society. Actually, she doesn't give a very specific definition, but says that it offers development of potential while allowing the person to choose for a best action for himself or herself at a given point of time. And nursing, of course, it was emphasized that holistic healthcare is central, and human science of persons and human health illness experiences are mediated through professional, personal, scientific, aesthetic, and ethical human interactions. And that is the basis of nursing. So this is the Watson's model. As you can see, the center is the patient and the family. And of course, the whole mind, body, spirit care is given to the patient. So, and every aspect caring moments occur, which we must identify and utilize. So utilization of the nursing process is very simple in the Watson's model. So let us see what are its implications. What are the theoretical implications? We know that any nursing theory must help us to give nursing care. That is what we expect, and that is what we want to teach the students also. So let us see how that is done. So here you can see, I have presented to you how Watson has decided on the hierarchy of needs. And if it is compared with Maslow's hierarchy, as you can see in the Maslow, the basic is the physiological need, the safety needs, these are the basic needs. Also similar to what Watson says is the lower order biophysical, survival needs, where Watson also says that these biophysical survival needs could be food, fluid, elimination, ventilation, etc. The psychosocial needs or functional needs, which are the second level of needs, which says like need for activity, inactivity, sexual needs, etc. The higher order psychosocial needs, which you can compare with, self-esteem and self-actualization, which is like the need for achievement and affiliation. And of course, the last one, the intrapersonal need or the growth-seeking needs, is again similar to Maslow's, the self-actualization need or the growth need, as even Maslow does identify. So this is a comparison, and this is exactly what we can use for utilizing the Watson's theory of transpersonal nursing. So if you compare it to the nursing process, this is how the nursing process will occur. In the assessment, it will involve observation, identifying problems, and developing the same like how we do assessment in the nursing process. Observe, identify, collect the data, verify the data, etc. The plan determines how variables will be examined, measured, also what further data we need to collect, and what sort of care should be given accordingly. The intervention will include the direct action, implementation of the plan, and collection of the data. So it is necessary that, by way of language, words, intuition, thought, processes, etc., you identify interventions, plan it along with the patient, allow the patient the choice of his actions and interventions. Of course, evaluation in the nursing process is compared to Watson's, the similar way analysis of whatever data and interventions you have done, what is the impact of your interventions, and sometimes it may give you a feedback that, oh, this problem is solved, but there is something new that has developed. So this is how it integrates with the nursing process. So this theoretically, I'm just trying to critique this Watson's theory. It has a very good strength because it helps us to give quality care and soul satisfying care. When you give care, you're absolutely satisfied because your caring moments have been identified and you have implemented loving, caring, kind, compassionate care. The client is placed in the context of the family, the community, the culture, his spiritual base, everything. So that is a very strong point of Watson's theory, and the patient is a focus. Whereas the limitations are that implementing Watson's theory is difficult because complex technology is increasing in care. Patient stays for a short time, so we don't have many caring moments with the patient. So we don't get much time for the patient to actually experience the nurses caring in the hospitals. Emphasis is on psychosocial needs of the person. So sometimes maybe while we are meeting the physical needs, we don't get time to make sure that the caring is felt by the patient. So let us take a case study. Since COVID, the current scenario is all about COVID, and it is such a, there are so many patients with COVID and hospitals are full of patients. I have just taken one example of a patient, a 59-year-old housewife who was admitted to the emergency hospital in a small hospital, not very far from her home. She looked anxious, she had fever, fatigue, oxygen saturation was low, she was suspected to have COVID. She was worried because her husband was already admitted to the same hospital with COVID. His oxygen saturation was less. Maintained on oxygen by mask. He was hypertensive. I'm sorry, that has his name. And in her family, there are 2 children who are grown up, married, having children. So all the family members were anxious because they were a close-knit family. and they were actually, literally in stress. And we know that in COVID, we don't allow patients, relatives to meet the patients. Also, the information system is such that within the ICU, the people who are taking care of don't come and give any information to the family, to the relatives, who are waiting out. And actually, I have seen this, the patients, relatives going into such a lot of stress and, becoming literally hysterical with stress. So it emphasized on what are the caring moments that we need to have, not only for the patients, but also for the relatives who are waiting outside anxiously for their patients. So I have just compared how the some of the observations can be compared to the caritas which Watson has emphasized on. So Saraswati has body ache, fever, her vitals are, blood pressure is high, her pulse rate is high, her temperature is high. So what aspect we can put into action? As a nurse, we will look at the lower order needs before attempting to go for the higher order needs. The lower order needs right now, she has body ache, she has fever, she has blood pressure, which needs to be taken care of. So of course, our diagnosis would relate to all these lower order needs. And then it would be like taking care of the fever, taking care of the discomfort related to the pain related. So interventions would of course be planned to take care of these basic needs which this patient is having. So her fever, her pain, her anxiety should be taken care of before she can actually understand what is going on with her husband. Because husband in the ICU means she was even more anxious that something may go wrong. And common people have such negative concepts, negative thoughts about patients in the ICU that they start thinking about everything that is the worst. So she was given dolo, she was given lorazepam to make her sleep for some time. She also said she has shortness of breath. Her pulse oximeter was found to be on the next day to be 87 on room care. So here we had to use certain what curative factors we could use, systematic use of scientific problem solving, which could be used for decision making. Ministering had to be done, oxygen administration. We minister, one of the character factors, the ninth factor is a ministering, like taking care of the lower order needs. So all this can be done along with taking care of the anxiety. There's a teaching learning moment here also. So the character factor which emphasizes on teaching learning could also be included here. So the intervention would be to take care of the teaching her about maybe prone position, giving her oxygen, teaching her how to do some deep breathing exercises to ensure that her oxygen levels rise. She is diagnosed with COVID. Her husband is in the ICU. He's on non-invasive ventilation and he's maintaining oxygen. So how can we approach this family? Because we know that the family outside who's waiting is waiting in a very, very anxious situation. So in this, we need to have sensitivity to self, to others. Here you also need, maybe sometimes you have to instill faith, instill hope in them that the worst is not going to happen. Have patience, have prayer, have, understanding their spiritual needs and helping them to come closer to one with the universe, one with the God, and helping them to, reach their self-acceptance and self-actualization levels, and allowing them to express their positive and negative feelings. But yes, I know that in COVID, nurses are so busy that they don't have time for going out and meeting with the relatives also and helping them, as well as the Saraswati who's admitted and worried about her husband. So these are things where we may miss the COVID caring patients, caring moments. So here it is necessary that we understand these things and help them to express their feelings. Also, here there is a teaching learning moment where we need to teach them about the prescriptions, follow up, quarantine, etc., and encouraging faith and hope that the husband is getting best treatment, and hopefully because he is NIV, he is maintaining his oxygen levels. They should keep their hope up and also keep giving strength and faith to the person who's sick. So these are some of the things. This is just a short case study which I thought I would share with you. to make you understand how caring moments are identified and how care can be given using the Watson's theory. To conclude, Watson says too often we underestimate the power of a touch, a smile, a kind word, a listening ear, an honest compliment, or the smallest act of caring, all of which have the potential to turn a life around. This is what I experienced as a teacher. We are talking all the while about students, about patients, but this I experienced when I'm taking care of my students. In this time when they are all so stressed, their family members are sick, some of them have lost their parents to COVID, and they have been going through some hell of a time. Also, we are being forced to work in the hospitals. This was a time when students needed love, care, and when we gave them a free day, allowed them to just play, enjoy, eat, and make merry, they were so happy. At the end of the day, they came and they said they enjoyed the day. That is what they needed, and that caring was made. When I spent a few minutes with one or two students and just asked them, "How are you, beta? What is happening in your life? How are you all managing?" One student had lost her father. So these are caring moments which we can utilize. So it's not that Watson's theory is applicable only to patient care. It's also applicable to nursing education. It's applicable to every aspect of our life. And that is why I feel very connected to this theory. This is what in this one quote, Watson has just, highlighted the essence of nursing. And she says, maybe this one moment with this one person is the very reason we are here on this earth at this time. And this is what I feel that each one of us should also think is true. We are here for this moment where we can change at least one life. When the day when one patient remembered me, the next day I still remember that when I was taking care of a cancer patient in TMC, and she was in her end stages. I was with her throughout the day. In fact, my duty time is over, but I still waited with her. And that night she passed away. The next day, her son was waiting for me in the hall. And he said, I wanted to meet you before I left, because my mother said, especially thank her. So that is what we are all here for. Let us remember that, and let us implement this caring science especially in this particular situation where we are all in. With that, these are my references. I hope I have been able to clarify the concept of Watson's theory of transpersonal caring. And I also hope that all of you are well in your own places, taking care, staying safe, protecting yourselves, your patients, and your families. Thank you.
Thank you, madam.
Dr. Pratibha.
Yeah, thank you so much making this presentation so beautiful. I request you to please kindly make College of Nursing as a host.
Ma'am, how should I do that?
In front of our the college logo, are you able to see in the participant list?
Yes.
Yeah. So you have to click करायचं ना? You have to click there.
Okay. I have clicked on it. Is it okay?
Yeah, it is done. It is done.
Right.
Okay, ma'am.
Okay. Thank you.
Yeah, because of the host, there are many who are waiting to get inside. They are not able to get in, so they
I'm
just get
so
in.
sorry.
I would like to pose one question to you, ma'am.
Yes, ma'am.
Would you like to advocate the nursing faculty who are teaching nursing foundation right in the first year to incorporate the nursing theory aspect while teaching? So by the time they come in the fourth year, so they are able to understand this concept more better way. Would you advocate this?
Ma'am, I will surely advocate this, because right, the thing is, the concept of theory, people feel is very difficult to understand, and that's a very wrong notion. Actually, it's very simple to understand. Like just before me also, Dr. Shobha has shown how very simply you can incorporate nursing theories into patient care. And this Watson's theory, which I discussed also, is such a simplified theory, which actually is centralized on caring only, which is all what we do in nursing. So I would definitely want teachers to incorporate teaching nursing theories to students in fundamentals of nursing, taking simple theories, not starting with complicated theories, basic, simple, holistic theories like Watson's or maybe OREM's. These simplistic theories which are holistic, and then start with that. May not be teaching them all the theories at the same time, but of course selected few which are important to understand it, which will help them in their future careers, that we should incorporate. I will definitely encourage the teachers to do that, so that by final year the
Thank you.
students can take over. Yes.
Thank you so much, ma'am. On behalf of Dr. Vittalrao K. Patil Foundation, College of Nursing, I'm so thankful to you for making this very good presentation. Okay. Now I welcome the third expert speaker on this topic to speak, Shri Devi.
Much, Pratibha, you were so generous about introducing me. I'm very grateful for that. And can you see my slides?
Yes, we can. We can.
Okay. So I will start actually by, I think my voice is very loud, so I don't have to ask about it. I just thought I will start by asking, taking a question that was there. Somebody, I don't remember the name of the person, I'm sorry. This is a correct question that somebody has asked, and that will be interesting. When somebody asks a question, I believe we must answer, then it keeps them motivated. So the first question that came along was, why are nursing theories not applicable in clinical settings, or something like this? Okay, because I'm not going back to that screen, I'm talking to you. So who's that person? If you want to ask it again, please put on your mic, or can Pratibha read that question?
Hello.
Yeah.
Good afternoon, ma'am. It was me who asked that question, ma'am.
Your name?
Pratibha Mohite, ma'am.
Ah, Pratibha Mohite. Okay.
Yes,
are you a
ma'am.
faculty? Are you a faculty?
Yes, ma'am. I'm faculty in V.K. Patil College of Nursing, ma'am.
Right. Good. Thank you. Thank you for this question, Pratibha.
Thank you,
There
ma'am.
are a few points that I would like to say. Do you really think we are not applying? I'm not asking, I'm just asking a theoretical question. I mean, a question not for expecting an answer. We are not applying the theories. Actually, we are. If you look, I mean, I have worked in KEM and in Mumbai. Currently, I am outside in Muscat. Probably it's the nurses. I mean, we as nurses, we feel, even I had the same question. So let me start with that, Pratibha. I used to have the same question even after my master's. So now I am 37 or 35 years after my master's. But when I studied master's, I honestly thought, let me tell you with hand on my heart, that theories were not applicable to clinical situations. This is how I started my journey. Now, there are many reasons why this can be happening, like why nurses perceive that it is not applicable to the clinical setting. And the first one of it is how these theories are taught. For example, I mean, I'm telling you that even when I was taught this theory, probably education methodology, I mean, I will grant it to my teachers, educational methodology was not so well advanced. I had a teacher who used to sit in front of a desk and just read the theories out. Probably did not relate it to the clinicals. Maybe the teacher herself has not been in clinical area for a long period of time or whatever. So the way these theories are taught, that is one of the reasons why we think we are not applying it to clinical settings. So I will be actually talking on Virginia Henderson's, which I like because it is one of the most practical theories. And this question that you're asking, I'm sure we will answer by the end of even talking about Virginia Henderson's theory. because this is one of the grand theories, and Orem's is another grand theory. Just now Shripriya was telling us that, you know, we can use simple theories like this to see care. Secondly, one is education. Second is when we apply theory in practice, or when we are really staff nurses in the clinical area, we do not put our head into thinking that we are really applying these theories, because it doesn't come in front of us in any way. It is not put up in our wards or in any areas, whether, you know, what kind of theory we are using for caring for patients. I'll give you an example of this. So what happens is we think what we are doing is all routine, but honestly, no, we are not doing routine things, because we were told to practice, or we were taught in a way which our teachers have taught us, whether it's clinical or whatever else it is. They didn't remind us that this action belongs to this theory. But when we learned it, finally, when you look back at the actions that we do and compare it to the theory, we will realize that we are really practicing these theories. The only other thing is that we don't apply it to ourselves or even to our students, and we don't think about it in the research. So it is just a myth in our head that we are not applying to clinical settings. But yes, in India, what's happening and what can be done to improve. Now, in 1996-97, like Pratibha said, I went to UK. So that is the first time, I'm telling you, I finished masters in 88. And in 96-97, when I went to UK, I went to in Royal Brompton Hospital. And the first ward I went to was called as the Elizabeth ward. And this is where they were looking after chronic COPD patients who were having lung volume reduction surgeries. That means they were taken to the theater, and all the damaged lung, all the emphysematous lung was actually cut and sutured by, you know, it's a technique of cutting and suturing, not literally by scissors. It's a device that actually cuts and heals the lung at the simultaneously. So all the emphysematous lung gets removed off, and then the patient's lungs start expanding naturally, and then the patient's condition becomes much better. That time it was a very, very brand new surgery, lung volume reduction surgery. So in that ward, and they had cardiac patients there. So in that ward, there was a little plaque, a small plaque that said that we as nursing staff believe in Orem's self-care theory, and we do everything possible to make sure that the patients are made independent at the earliest, etc., etc. This is just a small plaque that the nurses have put at the entrance of the ward, saying what theory they believe in. And what they did subsequently is, if in that ward, all the records that were maintained, whether it was an assessment record or a intervention record or a document record, even the way they cared for the patients, was all reflective of the Orem's self-care deficit theory. And this is when I realized 10 years after my master's, oh wow, this is how theory is used in the clinical setting. Now, I am not aware of, I've left India now quite a long time ago, but till the time I was there, we haven't had this kind of little plaques which show how nurses, this is the ward or the unit is supposed to be belonging to the nurses. So if we display what our belief is when we are looking after patients, these theories actually come alive. But we don't do this. We are kind of, so disconnected in India with patient care that we think, oh, it is not our responsibility. It is the doctors who are supposed to do everything for the patient. Absolutely opposite is what I experienced in Royal Brompton Hospital. We are the center of the healthcare system, like WHO is now saying. Nurses own the ward. Nurses own the patients. It is their patients. Everybody else actually just comes to coordinate care. But the final decision on whether to discharge the patient, whether to send the patient to the community, how to get the patient back for follow-up, every single thing was the responsibility of a nurse. And this I'm talking in 96, 97. So here is where we actually magnify our role so much. But for this to happen, we as nurses must see, we as nurses must set this example. We must move ahead and accept it. We must push and do these things. Just to put a plaque, even we can spend our own money. And if it is our unit, what is so hard to say? And each unit actually, I went to another ward, they had a different theory because their type of patients were different in the other wards. So if they are in the ICU, they had an enabling theory, which was very different from the theory that was used in the medical ward or in the medical unit, where the post-operative unit where these patients were being nursed. So it is a matter of visualizing, and these are all nurses, I tell you, believe me, in the unit in 96, 97, they were all 3-year diploma holder nurses working in that ward. Only the ward sister was a bachelor's. They were not masters holding people, but they had so much idea of how to utilize nursing theories, its importance and its implications. So I think there's a big paradigm shift to be made, and we have to make it. We cannot wait for somebody else to come and make this. Pratibha, Mohite, did I answer your question?
Yes, ma'am. Thank you so much, ma'am.
Hmm?
Yes, ma'am. It definitely answered my question, ma'am. Thank you so much, ma'am.
I hope I convinced everybody who is listening to these things. Okay.
Yes, ma'am.
Let me start. Yeah, thank you so much. And Pratibha, thank you so much for your generous introduction. I don't know whether I can stand up to that, nor do I know whether I can stand up to the stand up to Dr. Shobha's and Shri Priya's presentation. And I'm definitely not doing that in-depth a presentation, but I will give you tons of examples of how these nursing theories can be used in what kind of patients. And I think that's the best contribution I can make. I'm more of a clinical person, though I teach, and I've been teaching for over 25 years in the 37. I think things should be made easier and easier and easier just for them to realize. So just keeping the audience in mind, I haven't done too much of details. Okay. Now, usually, if you look at theories, and nobody gave an introduction. So I just quickly give you an introduction, though Pratibha did give an introduction on theories. On nursing theory, she directly said, but I would go a little behind. In school, we have learned Pythagoras theory, right? Pythagoras theorem, where we say that the hypotenuse is shorter than the right angles. Hello? I'm getting disturbed.
Chano Bhattacharya madam, please.
Okay. Thank you. So if you look at the two right angles, hypotenuse is shorter than the two right angles. Till today, if I am walking in any open space, and if I want to do a shortcut, I use this theory. So what I do, I avoid the right angles and I take an angular method of crossing a garden. And I know that I will reach faster at that point than using the right angles, because in school, I learned the Pythagoras theorem. It was I remember still now in my school days how hard it was for me when in exam they asked, prove Pythagoras theorem. And oh my God, I did not know what kind of steps have to be put into it. I memorized it. And I passed my exams. I'm glad I'm not too bad at maths even today. So, but I understood that. But I understood Pythagoras theorem practically when I have to walk through huge spaces. I know that the hypotenuse is shorter. So definitely any theorem. So if it's a maths theorem that is so useful to us, we know Darwin's theory. We know the Darwin's theory of evolution, where they say that only the fittest will survive. You look at COVID, and you will know that Darwin's theory really works. It's a theory that makes sense. Because if you look at COVID now, only the fittest are surviving. So yesterday I had one of my I have two of my school friends who died. I had yesterday another friend of mine who's much younger than me in Bangalore die. All of them were obese. And I'm thinking in my head already today that Corona will not spare anybody who's obese, because all these three friends who died were obese, were overweight. So it's a theory. So it is about fittest. Only the fittest will survive. If you look at it, Darwin's theory still works very much in COVID. Like Pratibha said, we don't have to have a nursing theory. You can use Darwin's theory to understand how patients will survive honestly now. Similarly, look at Einstein's theory. So all these people who predicted theory, it was useful for us. It is difficult for us to understand. But over the years, we will be able to identify its use. Yes, our brains are limited in its abstract thinking. Theories are a lot abstract. And it took me many years. So don't curse yourself. Don't be upset with yourself Don't be blaming anybody, because I went through all these stages, and that's why I'm telling you, it is hard to understand. So what happens is, when you get an opportunity, like I said, how I used my Pythagoras theorem and remembered it, I hated it in school. You will be able to recollect the theory, and you might want to think about it. So if it is, I mean, it is not used in nursing. See, here is Pratibha's question. So it is unused. I already gave you a reason, so I will not waste my time. So if we want to be a profession, which we very much must be, because we are not going to follow a medical model of care, because a medical model of care is very different from a nursing model of care, and we are nurses. So we must have our own background to understand how things are. Like, so for example, caring, she said. So like Sri Priya said about caring, now caring is not natural to everybody. We as nurses, we feel, oh, what is that? I mean, we devalue ourselves, or we do not give adequate value to what we are doing, honestly. Or this is how I think that we are all perceiving it. Pardon me if I'm generalizing, but I'm 57, and I think at this stage of life, I have lots of experience to tell the general thinking about this. So we actually devalue caring, thinking it is a very easy thing, but it doesn't happen. See, if you see a doctor who is telling a bad news to a patient, or who is just prescribing and writing in a bad, I mean, the handwriting is not legible, or says, you will be all right, don't worry, everything will be all right. You think this is what we do is not different from this? It is very different from this, because what they are saying many times could be false reassurance. They probably think it's a matter of fact, while everything in life is not a matter of fact. Everything is not black and white. People like to be cared for. People like to be explained what is happening. I can give you tons of examples in the last few days that has happened to me. I have a friend whose niece in Canada having stage 4 cancer, with a baby which is 1 month old. 38-year-old Deepthi has a 1 month old. It's a crowdfunding going on currently. Delivered 1 month ago, and she's the niece of my classmate, school friend. And this girl had a lump in January in her breast, and by the time she delivered, it has become stage 4. It has spread into her liver, bones, spleen, lymph nodes, and I'm not sure whether it's lungs, but ribs, and spinal cord. A 38-year-old with this. And then I was talking to her auntie, that is my friend, and telling that, so my friend was telling, oh, I told my elder sister everything will be all right. I said, no, Anita, everything will not be all right. Actually, it is going to be hard. So what we need to tell your sister or the mother of that 38-year-old is that to stay strong and understand that everything that we do is for the best, and we are doing our maximum, but they should have other plans in mind about how the children should be looked after, how the husband might need a break, or might need to later on in life have somebody else in their life. So everything will not be all right. And I told Anita, my friend, please don't say this word. We hope, we all want to hear everything will be all right, but that's not going to happen. So better than false reassurances, to tell people to stay strong and that you will meet the problem when it comes. She might live 1 year or 2 years. Let her live happily. When her end comes, we will see what to do next. This is a better advice than, so that comes from caring, that comes from honest understanding of the problems of people. So there's a big difference between my classmate who is not a nurse, a doctor who is trying to treat the patient with chemotherapy or whatever else, and us preparing the family and helping the patient to stay strong during these difficult times. And this will come only out of understanding a lot of things. So this is important. Disciplines without a strong theory and research base will have a problem, will be referred to as a soft or a negative comparison. And we in nursing also already have this, like we have a negative comparison because our principles are not purely science based. It is based on psychology, sociology, science, and so many other things. So quickly, I don't want to waste my time on this. Just to quickly tell you, nursing theories are patterns that guide the thinking about nursing. So we are doing this from long time. Our thinking is guided by nursing theories, but we don't recognize this for various reasons. In every theory, there are 4 things to keep in mind, and I'm not going to go through all these details while I discuss Virginia, Henderson, and Oren's. You have already got an example of it from the other 2 people. So I will focus mostly on nurse or nursing because this is what I'm interested in. The rest of it is very much important. I will not deny that fact. But just to give a practical aspect to these things, I will not delve in detail in this. I will answer any questions that are coming across in this. So before I go to Virginia Henderson, I just wanted to add a remark to what Dr. Shobha told you. Dr. Shobha told you about Erickson's theory. This is one of my favorite theories in my personal life. And all of you, I advise you to think or learn or understand Erickson's theory very, very carefully. I used it on my daughter. I have only one child. And as she was born, from her birth till now, she's 32 now, I have been constantly following Erickson's theory to understand my child, because I had, let me tell you, very difficult times. Those of you who are young students, like teenagers between the age of 18 to 22 or something like this, or who are still in College of Nursing in the beginning, I had a tough time with my daughter during these times when she was 18, 19, 20, 21, 22. Because during these times, me and my daughter used to have terrible arguments. She used to get very angry and upset with me. And I was actually going crazy mad thinking, oh my God, how am I going to deal with this child? When Erickson's theory showed me that in this stage of life, in this stage of development, children are actually following intimacy versus rebellion. So Shobha, am I right? If you're there, you can tell me yes or no. Children at adolescents go through this Erickson's theory of development, where it is intimacy versus rebellion. And I realized that, oh my God, I am a nurse. And if I have to get things right with my daughter, if I fight with her, if I'm going to be rebellious and saying no to everything that she's telling me, I will actually lose my child. I will actually have her hating me. So to the extent that she told me, this was, now she's 32. This was about when she was 18 or 19. She told me that she wants to color her hair. She wants some red color on her hair. And I said, you know how traditional we could be. We don't color our hair, and then we sit and think of, no, it is not necessary. It will spoil your hair and you will look stupid and blah, blah. That is a typical motherly instinct that came out of me. Then I realized that she kept insisting, and I said, okay, we will do it. So she said, Mommy, you can help me color my hair. So we went to the supermarket and we bought whatever color she wanted, Garnier, whatever. She told me that this has to be mixed, and then you put it on the hair, and then you put an aluminium foil around it. She explained to me, because youngsters know what to do. She told me, this is how you color the hair. And I followed her instructions. I was trying to be intimate. I got her hair colored the way she wanted me to color it. And I looked at it and I said, okay, if this is what you want, it's only hair. I changed my perception, because I said, oh, it's only hair. Why am I fighting with her? It's only hair. Hair will grow again, or the worst come to worst, it can be cut and then she will grow her normal hair, etc., etc. I colored her hair, and then after 6 months, her hair became all like messy and bushy and whatever. And that was the end of hair coloring. She never asked for color anymore, and she decided to give up that thought process. Now, what I'm trying to say is, in Erickson's, if I had gone rebellious with her, probably she would have kept going into the defense mode, colored her hair more and more, just to prove to me that I will do what I want. And anyway, she was in a boarding school and she could still have done anything that she wanted to do. But being intimate, I got my point through. I made her happy. And finally, she decided that she will not color anymore, because her hair didn't look very nice after a few months. And she realized it was difficult to maintain that system and very expensive, and she will not have access to a parlor, etc., etc. So Erickson's is an extremely personal life example that I'm giving you. Today I stand and I look at another example of what she said, generativity versus what did she just say? So
Stagnation.
Stagnation, yes. So at 57, honestly, every single day, me, myself, I, Shri Devi, I'm looking back at life and seeing whether in the last 37 or 40 years, have I been have I produced or have I produced or given to society? Do I feel that I was a very person who generated good things in life, or am I stagnating? I still think about it even when I'm talking to all of you. The moment I get in the Facebook, my ex-students who write to me how good a teacher you were, or how good a role model you were, or how you how you made, were a good mentor in my life. I get plenty of this feedback at this moment from various sources, and I'm thinking, okay, this gives me an evaluation that I am not stagnant. I have been generating students or practitioners who have now grown so much that this Erickson's theory is a real life example. I've nothing else you learn. Don't have to learn about Virginia Henderson or what I talk. What she told you, think about it every day in your life when you're dealing with your children, when you're dealing with your students. When I deal with my students, I keep Erickson's principle in mind. I realized if my daughter was going through intimacy versus rebellion, I cannot deal with this BSc nursing students unless I am intimate with them. If I make them rebellious, I'm going to only fail. I'll be a miserable teacher. I will not produce good students. So I have realized that being intimate with them, at the same time being firm, is very helpful. So education wise, I can see this as a beautiful example. So thank you, Shobha, for taking that theory. It's one of my favorites. I never thought about it. So quickly going to, I will not take too much more time. I think I finished all my time by this time. Pratibha, a few minutes, I will just tell them Virginia Henderson and Orams if it's okay with you.
Yeah,
Okay.
please go ahead.
Yeah. Okay.
Quickly, you review.
Yeah, finish. So Virginia Henderson is a real practical theory. I'm not going to take much time off this. So Henderson, I mean, all the important information about theories you can find in nurse labs. So she was born in Missouri. She had a diploma. Those days there was only a diploma, BS and MA. And when Henderson and Orams had a lot of doctorates, honorary doctorates from various universities given to them. Henderson and Oram have written different textbooks, and this textbook of Henderson on principles and practice of nursing is one of the very favorite textbooks for basic students. she died in recent times, but one of the first definitions that we learn is of nursing is coming from Henderson. I still remember my teacher teaching this to us. So what is the function of a nurse? To assist an individual, sick or well. Now this theory, what you need to take home is that Henderson actually wanted us to be nurses not only for sick patients. She was one of the earliest people who said about health promotion. So when we say well, like I am well at the moment, I'm at home. All of you people, students and faculty are well wherever you're sitting. That is why you're sitting and listening to this class, because in Maslow's hierarchy, you will not have information need unless your basic physiological needs are met. So you're sitting comfortably somewhere after meeting your basic physiological needs. So in the performance of those activities that contribute to health or its recovery. So if I'm teaching a person to do, teaching a healthy person that you must do 30 minutes exercise, I am teaching a person who is well to maintain their health. If I teach somebody why they should take medications, yesterday I had a friend who said, oh, I'm taking a lot of pain medications. And I told her, do you realize that all these pain medications can harm the kidneys? This is another school friend of mine. And she said, no, I didn't. Then I said, yes, you have pain, you should take medications, but make sure you drink 3 liters of water or else your kidney will go for a toss. So when I'm teaching somebody who's unwell, I'm actually also doing health promotion, but I'm doing a nursing activity. And the best thing about Henderson's, which I like, and I always teach my students, is if we cannot see, this is the difference between medical model and nursing model. If we cannot help them with health, we can always, as nurses, help them with a peaceful death. And this is so beautiful. I take pride in feeling that why I like to be a nurse, even in the next life, is because only in nursing we are allowed to understand that people can die. And they should be allowed to die peacefully. And this is something that, and we don't fight it. Like, unlike the doctors who think that if they cannot cure somebody, then they think it is their failure. They feel they have failed. While we in nursing don't think we have failed. We are happy and we know that people have to one day go. Each of us have to go one day. So we would perform unaided. So if any activity that we will perform, see, today I can talk to you because I can breathe. But tomorrow, if I have a breathing difficulty, you, my nurses, if you are my nurse, you have to help me to breathe so that I can talk. If I cannot breathe, I cannot eat. This is why COPD patients are not able to eat, and they lose weight, and they develop, and they have so much of difficulty with breathing that their chest shape becomes different. So these people, you need to aid them to breathe so that they can eat, because we can only do one thing at a time, either breathe or eat. So any activity simple you take, and you will be able to understand why nurses are important. So if they had the strength, which they would do, you see, I can breathe now without your help. But if I had no strength to breathe, then I need a nurse who will help me to sit up in Fowler's position, who will give me oxygen, who will speak to me and say how to do a proper breathing technique. And if I have the will, if I had the will, I will do whatever I need to do. I can stop talking, not talk at the moment. But if I have no will, then anybody can do anything to me. So this is the time I need the nurse to protect me. If I have no knowledge, like I said about the medication, if I have no knowledge, then I need the nurse to teach me how to remain healthy. So this becomes a function of the nurse. And what we need to do is to finish, to make the individual get well as soon as possible. Nobody wants to stay sick. Even when we have COVID, I'm sure people who have had COVID will tell you, you are 15 days sitting in a room. I had another friend who told me, it's such a punishment to stay alone, isolated in a room, though you have everything else. You may have air condition, you may have food, no need to cook. Life is easy, but these are people who are even more suffering than anybody else. So basically 4 major concepts in this as well. And out of this, the last one is that the basic concept of nursing carried out by the nurse is caring for the patient. 1 second. Oh my God. So what is Virginia Henderson telling you? The Virginia Henderson actually emphasizes the importance of increasing independence for people. And I like this because it's very simple. There are 14 needs. I don't have to explain. That is why I did not make too many slides on this. So I need to breathe. And if I cannot breathe, then I need a nurse to help me to breathe until I can become independent of the problem. So it might be helping me to breathe, giving me medications to breathe, giving me nebulizations, whatever else, until I become free and independent to do it by myself. If I cannot eat, I need the nurse to feed me, or to give me intravenous fluids, or to feed me through the nasogastric tube until I am able to eat by myself. So I will not go through each of them. Sleep, pray, social activities. You look at Virginia Henderson's 14 needs, and you will realize that there are majority of them are physical needs, but there are also psychosocial needs, spiritual needs. So if you look at this concept, this theory, not only Pratibha, everybody else who's listening to me, are we really applying theory to practice? Yes, every single minute, if you are in a hospital, or you are in a community health center, or even if you're a friend to other non-medical friends or non-nursing friends, we are using Virginia Henderson's theory of needs theory, and this is most important. So Virginia Henderson's had this, her major thing about theory was the needs theory. So in the needs theory, she says that most important thing to understand is that the patient's independence, emphasizes on the importance of increasing the patient's independence, which is similar to Orem's theory. I'm going to finish that quickly. It emphasizes that basic human needs and how nurses can assist in meeting these needs. If I cannot take a bath today and I'm smelling and sweaty, as a nurse, you are really fulfilling a need of mine. And though nurses, this is the problem with nurses. Nurses think, oh, giving bath to a patient is nothing so big. Can a doctor do it? Can a physiotherapist do it? Can a dietitian do this? Can a family member do this? Maybe yes, a mother can do to some extent, but to some extent. But how much can a mother do if somebody is unconscious, goes into intensive care unit, or in a COVID when there is isolation and only a nurse is available? Who else could do this better? So it emphasizes on the human needs and how nurses can assist in meeting these needs. So remember that Henderson always visualized that nurses function independently, and we are functioning independently. I don't know how we feel so miserable giving a bath, making a bed, communicating with the patients, assessing the patients head to toe, listening to them, identifying their problems, monitoring them. This is not something that anybody told us. We learned it because we are nurses and we were educated to be nurses. So this function is seen to be complex and creative. It is offering us unlimited opportunity to apply physical, biological, and social sciences and development of skills based on them. I'm not going to go to the rest of it because if you look at the examples, I have not given you a case study, but I can tell you tens of examples like this where Virginia Henderson's needs theory can be used practically. This is why I brought it to all of you, irrespective of what levels you all are on. You should believe that you're 100% applying Henderson's theory. So just to conclude Henderson's theory, what we have to do, empathy. So actually, this is Henderson's own words. To get inside the patient's skin, to feel from inside the patient and supplement the patient's strength. The patient is feeling anxious, fearful. So you are there as the strength of the patient. The patient is saying, no, I'm not going to make through this COVID. I recently helped somebody like that because they didn't have the will to live. And I said, no, you will live. You just need to do these few things. So don't give up. They don't have the knowledge. So I become the knowledge of this patient. So we have this whole thing. The nurses have responsibility to assess patients' need, help them with the health needs, provide an environment in which patients can perform all their activities unaided. So this is quickly Henderson's. I will go to the next one. ORMs I like because I saw this being utilized in the UK, and I will give you a continuous example. I will not read through this ORM's life story, and I will talk about ORM's self-care theory. The self-care theory is also known as self-care deficit theory. Deficit means what? We know deficit fluid volume. This is a nursing diagnosis, you understand. Deficit electrolyte imbalance or deficit is there in many things. Deficit fluid volume is the easiest that comes to my mind. Something that is less. So in self-care deficit theory, this focuses on the other question that somebody else asked me. So this theory actually talks about if patients are sick, about how much they can do. If they are independent, then their deficit is less. But if they are dependent or they are depending on how much help they need, we use this theory. So here the nurse covers the deficit for the patient so that the patient becomes able to do self-care. So this deficit is what is covered by the nurses. So this theory focuses on individuals' ability to perform self-care. We all like to perform self-care, and is defined as a practice of activities that individuals, we all want to, I don't want to read this to you, we all want to stay alive. So we eat, we drink, we breathe, we take bath, we take medicines, we treat our illnesses because we want to maintain life and health. And we also want to have well-being. So we meet people, we communicate. Even these talks that we arrange are for actually our well-being. That means the principal and the faculty or people like me who are talking about it is trying to convey well-being, our own well-being, as well as help you to care for patients through this thinking. So there are three interrelated theories. I will again not read them. These are all things that you all can read by yourself. Now, in this self-care deficit theory, I want to focus on that nursing is required when an adult, or in case of a dependent, the parent or the guardian is incapable of or limited in providing effective self-care. So when I cannot effectively provide self-care, I need help. So if a mother of a child who's got Hirschsprung's disease doesn't know what to do with this child, how to care for this baby, or there is a cleft lip or a cleft palate, and the child is not gaining weight and she's not able to feed, then she needs a nurse, because she needs to learn from a nurse how to feed this baby, what can be done to maintain health and effectively self-care as soon as possible, so that they don't have to stay in the hospital. So the interrelated theories include, I mean, there are other two theories. There is theory of self-care, that we all perform activities for maintaining our self-care, and the theory of nursing systems. That means there's a relationship between the nurse and the patient, a legitimate nurse and a legitimate patient. So these, when they get activated, etc., these become a little theoretical, so I'm going to not go through much of it. Now, what we do in Orem's theory is patients are encouraged to bring out the best in them despite being ill for a long period of time. I want to give this example here, and I'm almost done. So in UK, in this place where there is lung volume reduction surgery is done for COPD patients or patients who have smokers' lungs, these patients go for surgery and come back with intercostal drain on the left side as well as the right side of the lung. They have ICD drainage on the left as well as the right side of the body, because it takes time, unless because of the surgery there will be pleural effusion because we have cut the pleura, and for the lung to expand because we have cut the lung as well. So, and then there is unbearable pain, as you can see, because if you put ICDs, we should know ICDs are more painful than actually having a your sternum cut in an open heart surgery. So in this ward where they were believing in Orem's theory, what they did, and it was so beautiful for me to see that how they would mobilize patients. They first of all wanted to mobilize patients in less than 24 hours. As soon as the patient comes, within 24 hours, it becomes the objective of the nurses to actually make the patient stand up. They must. So what they do, they control the patient's pain. What else does not, so that's a deficit. Pain will prevent the patient from moving. What else is deficit? The patient is afraid, the patient is anxious, they don't know that, they feel that they will not be able to do it. So the nurses support them, communicate with them, and guide them, and be their strength, and stand next to them until they stand up. Now, by the time it is second or third day, then they need the patients to be mobilized, because lungs cannot expand, as you know from simple anatomy physiology. Until you move, until you mobilize yourself, there is no way that lungs will expand adequately. How they mobilize patients with two intercostal drains. While when I was a student, I never saw patients with intercostal drain move, because it was a glass bottle and it used to sit to the side of the bed and the patient was stuck to the bed. And we used to do physiotherapy. This in 96-97, when I went to UK, I saw these intercostal drain patients. What the nurses had developed to make the patient independent are these little push carts. I don't know how to call it, and we use it for playing as children. We have this two-wheeled cart in which there is a big long handle, and you use this cart and go playing, or we even say we are going shopping, etc. This tiny two-wheeled carts, two carts like that, into which both the intercostal drainage bottles are kept in two hands, and the patient holds these two sticks or these two cart wheels, and the patient is mobilized with two intercostal drainage. The true spirit of Orem's self-care deficit theory is practiced. This is just one innovation that I want to talk about. So if we really believe in theories, we can actually innovate in nursing care. And seeing is believing, implementation is the key. And our problem is we don't bother and we don't want to implement. So this is just one example. If you look at how many innovations can be done if you believe in theories and make sure. So if you're believing in Orem's and you want the patient to be able to care for themselves despite being ill for a long period of time. So take examples of paralytic patients. If the patient is, my father-in-law was paralytic, and how I used my nursing care to the best. I remember that he was afraid to get up from bed because one side was weak. And I took a week's leave. I was working Hindujas, and I stood by him and said, you can do this. I gave him limb physiotherapy. I supported him or stood as a crutch on the weak side and said that if you fall, I am there to support you. These are huge activities nurses are doing to support patients. And so this brings the best in them. And we don't give it a value. We think as nurses, oh, this is something that everybody can do. No, not everybody can do. It's very applicable in rehabilitation settings. So in cardiac rehabilitation in UK also, I saw this. Independent.
Hello,
Finished?
Sri.
Yeah, I'm done. Hello? Just one more minute.
Hello,
Yeah,
Sri.
so-
I'm so sorry,
yeah.
but the time is
No,
a
I'm
big
finished.
constraint. Yeah, please conclude.
No,
Yeah.
no, finish it. Okay. Primary care settings where patients can be independent. So just to give you this few examples. So I'm not going to go to the definition of nursing, just told you already all these things. So we provide specialized in nursing in Orem's theory. We provide specialized assistance to persons with disabilities. I hope I'm explaining what somebody asked. And we are making more than ordinary assistance necessary to meet self-care needs of patients. So this is the most important thing that nurses are doing to contribute. Ask yourself if you are doing this or not. Only thing probably you're not doing is not innovating, like I gave you an example. So in living theories, I finished. We can live theories like in education, we can live theories like adult learning theory, caring theory can be used on students. So many theories can be done. Clinical practice, we can use so many theories. In research, you can identify conceptual frameworks to generate new ideas, research questions. These are all specializations of all the PhD. So I will be very humble enough not to talk or dare to talk about it. And I will tell you more you can read in nurse labs, but think about it and you will know that we are really using these theories, and it's only a myth that we don't, because we cannot talk about it. We are unable to talk about it, and we are unable to point out when we are clinical or practical nurses which theory we are using. Thank you very much for your patient listening. Sorry, Pratibha, sorry, my co-panelist, for taking this time, but I thought living this theory is very, very important. I hope I've made a difference to your idea of theories. Thank you so much.
Thank you so much. Shri, can you make us host, please?
Yeah, I will. Let me
Yes.
let me go. Let me go there, please. 1 second.
Yeah.
College of
Giving such a beautiful presentation. And I am extremely sorry for giving less time to you.
How do I, 1 second, what do I do? You also have to explain to me again now. Hello?
I think we got
Can you
it.
explain? You got it? Okay, good, good, good.
Yeah. Go to the College of Nursing. Yeah.
I have College of Nursing with me.
You have
Yes.
to click there.
Yeah, I made you host. I made you host.
Yeah, just click there.
I clicked it. Your host
Okay,
already, I saw
okay,
it.
Yeah. Okay. Yeah. Thank you so much, and answering the questions also, and making the discussion more lively by quoting so many illustrations with the examples. I'm sure the examples have enlightened the concept of how to apply the theory into daily practice. I'm sure the faculty and the students who have attended, and even this is on the YouTube, so many can access even later this presentation and can be benefited out of this, because we think theories are very difficult, they are gray and cannot be applied, but actually in day-to-day life we are using it. And all these nursing theorists, how they have come up with these theories and models while doing their doctoral research, they have come up. In the beginning, we know that we borrowed the theories from psychology or sociology, but then these nursing theorists, during their doctoral, they have come up with these theories. And I'm sure with this application of nursing theories in clinical practice and research, all these three experts so beautifully they have illustrated with the live examples, and surely we will apply it in our day-to-day practice and also use it in the research, and maybe hope some PhD scholars can take up this example and use it to develop some theory or model which may be applied in our clinical practice. Once again, thank you so much. Over to you, Amol.
Thank you, ma'am. Good afternoon, one and all. I, Mr. Amol Timkar, on behalf of Dr. Vithalrao Vikhe Patil College of Nursing and entire organization team, take the privilege to propose vote of thanks. I take this opportunity to extend my most sincere thanks and deep sense of appreciation to our guest speakers, Dr. Shripriya Gopal Krishnan, Dr. Shobha Gaikwad, Mrs. Sridevi Balchandran, for gracing the virtual webinar and sharing with us your knowledge and opinions today. We extend our gratitude towards the management of Dr. Vittalrao Vikhe Patil Foundation, Secretary General, Lieutenant General Dr. B. Sadananda, Deputy Director Dr. Abhijit Dute, Dr. Vittalrao Vikhe Patil Foundation's Institute of Medical Sciences for their support and cooperation. I also take opportunity to mention our gratitude towards respected Principal Madam, Dr. Pratibha Chandekar, for providing encouragement at every point of time in organization of the webinar. We have been fortunate enough to be backed by a team of very motivated and dedicated colleagues who know their job and are result oriented. I cannot thank everyone enough for their involvement and their willingness to take on the completion of tasks beyond their comfort zone. I want to state that we are all almost grateful to all the virtual audience. We thank you for being with us this day. It's been a great pleasure. Thank you very much. Have a great day ahead. Thank you.
डिस्कनेक्ट झाला आपला
नाही. एक सेकंड. नाही दिसतो ना.
Yes, Dr. Shobha, thank you so much.
Thank you, Dr. Pratibha.
Yeah.
Excellent arrangement, very well arranged.
Yeah. You know, because of the time constraint,
Right.
we are not able to, give more time to each one of you.
It was nice connecting to Ms. Sri Devi and Ms. Sri Priya after a long time here on the
I know.
virtual platform.
Correct, correct.
Yes, thank you, ma'am, for giving us that opportunity to connect after such a long time.
Yes.
And of course, being on the platform was also very
I know.
enlightening to us.
Correct, correct.
Thank you.
Thank you. Thank you. Thank you so much for all who got connected. Thank you. Thank you, Shri.
I'm saying I'm not very expert like all of them, but I really apply it practically.
Hey, don't say that.
No,
See,
because
see,
We have
each,
given lot
each
of,
one has
daily life examples,
Hmm.
That is what is important,
Correct.
incorporating theory in various ways. Okay, that
Correct.
we actually have seen.
It was
okay, Chris is saying, Chris has asked a question and he's writing to me that his question was not answered. Oh my God, that was very
Yeah.
important. Chris, 1 second. Chris has asked a question. Anybody of you can do this. Okay, where is this? His question was, what is the procedure or format to get nursing theory standardized uniformly in India? How to go about it through research? Some nursing scholars do generate new theories, but it is in dump after presentation, not utilized. So how to make it uniformly accepted in India? Who's the authority to make it standardized? Anybody who has an answer to this question?
Even one
I
more
think-
person had asked, Rajesh Joshi. He also from Gujarat. He also asked about the same format.
I think in
So-
India per se, we have not patented there. As he rightly told, there are many theories we do. Okay, but they are just lying in the pieces or it is dumped somewhere. So I think the council has to come forward and make a committee, for patenting these theories. And then I think those theories can be patented with a particular name. That is what I think he is meaning, because all what that we are following are theories which are there in the book. There are many new theories. As I told you, we do a combination of theories also, but it is not patented. It is all lying in the book. It is not there for the people to see. So somewhere we all need to come forward and make a body first and foremost. Okay, at present in India, there is no body where theories are patented as far as I know, because I did try to find it out some years back, and then I just forgot about it. Okay. So rightly pointed, I think
Okay, Chris, I have this answer for you. If Shobha, if you finished, I have this answer. Let's see, Shobha, if your students have made a theory or they have utilized a theory very effectively, my suggestion is, see, there is, just like there is no standardization, there is nobody stopping us. So
Right.
for example, if you have a student who's come from KEM hospital and who's doing MSc with you, I would, and that person has used a theory and written an MSN paper, we need to encourage them. She's going back even as a staff nurse to a unit in her ward, she needs to put it into practice. She needs to see, she needs to have enough communication skills to convince her friends that at least for 6 months, please can you help me to try this out. If it doesn't work, then we will try something else or we will take somebody else's suggestion. But I did so much of effort, can we have it working for 6 months or 1 year? See, in UK, what I saw was nobody stops anybody. So if every director of nursing of a hospital, corporate hospital, we have all educated nurses, right? Our own people, LT people, so many are there. If each of them told their wards that we encourage you to use something that you think can be used, and we will put up a small plaque that says that this ward uses this nursing theory. I'm using Virginia Henderson's nursing theory. Then, and make, so they can do it by themselves. Nobody will stop them. We don't need to standardize because theory cannot be standardized. Can it be, Shobha? Because each patient has a different need. So if you have a group of patients, like I said, in the UK where I worked, there was this post-operative patients. For that post-operative patients, which were all usually like that, no, medical ward, surgical ward, burns ward, pediatric ward. So you have a group of patients who are similar. You can use one theory which is most applicable to them. You cannot have a hospital having the same theory. But this has to come from somewhere. I mean, like, for example, Chris, if you're doing a gratitude theory and if you are in psychiatry or in a wellness clinic, Chris is working on a PhD in gratitude. So I would think that this could be taught to students. Students could every day start with gratitude. They should actually be even in their wellness clinics or their psychiatric clinics or even nurses, daily nurses who, normal nurses going to clinical areas must practice gratitude. It can be done. You're talking of a theory or building on a theory, intervention called gratitude. So wherever in global where you're working, you should make it a practice. I think this is how it will work. This will not work across the country. Even if councils tell you, it is like the government rule. Don't do this, then wear mask, we don't wear mask. Vaccinate, we won't vaccinate. So we do exactly opposite of what anybody tells us. This is our mental attitude. So no need to standardize it. Think about utilizing it regularly.
Definitely, I think the takeaway is the plaque putting on the ward of the theory. I think that is the takeaway from the conference for everyone who's attending it.
I think in addition to that, I mean, I do agree with Dr. Shobha as well as Sri Devi ma'am regarding, patenting the theory as well as putting it into practice. I think putting it into practice will help us to develop the theory and, give it a format. And patenting it gives you a copyright. But in between that, maybe publicizing it, making it known to other nursing professionals by use of publications or by producing a book or something on it. We need not make a very big book, but even a small ebook which may help us to, spread the news, spread the information about the theory that has been generated by one of our own members, maybe in India, would also be very useful in helping to others to know about the theory and putting it in practice. Of course, putting a plaque and saying that yes, we are utilizing this theory will help us to definitely, make others know that we are following some particular way of giving nursing and bring nursing into focus. So those are two definite good suggestions which are there. But in addition, I also feel that publications would help in.
Sure, Shripya, you're right. See, the point is we are not talking. We don't. What is opposite to America? They do little, but they talk a lot about it. We do a lot,
Yes.
but we never mention a word about it. We don't breathe about it, as if we don't exist. This is our problem.
You put it very simply, ma'am. Absolutely right.
Okay, thank you, ma'am. Thank you very much. So we are here to conclude the webinar. Thank you once again. So we are concluding the session. Thank you.
You may.
Yeah, thank you.